Hi, everyone. Welcome to poster session 9, Integrating Digital Services in Healthcare Systems. We have some great topics, great presenters today. I'm very excited. Presenters will have about 2 minutes to give an overview of their poster, and then we'll open it up for questions. During the presentations, please keep yourself muted. So when it's open for questions, feel free to unmute yourself to ask a question, or you can submit your question in the chat. So let's go ahead and get started. First up, we have Dr. Jeane Bosch.
Hi, actually, Catherine Tang will be presenting the poster on our team's behalf.
Okay, great. Thanks you. Please go ahead and share your screen.
Hello, everyone. Just a second while I share my screen. Can everyone see it?
Yes.
Perfect. Okay, so hi, everyone. My name is Catherine Tang, and I'm an undergraduate at the University of Pennsylvania, representing the Tech into Care team at the VA National Center for PTSD. And for purposes of this poster, I have no conflicts of interest to disclose. So starting off with some quick background, the VA's National Center for PTSD has developed a wide array of free self-help mobile apps for PTSD and other related conditions. And if you'd like to learn more, please feel free to scan the QR code at the bottom right of the poster. Despite their numerous benefits, however, these apps remain vastly underutilized by veterans. So in response, the Tech into Care team has developed the Tech into Care Plus pilot project, which is a self-guided internet-based tool that helps VA providers develop a tailored implementation plan to better integrate mental health apps into their work. So in terms of methods, participants for this pilot project included 19 VA staff from different VA medical centers who have expressed an interest in integrating mental health apps into their work with veterans. They first completed the mobile mental health implementation decision tool, which included a needs assessment. And then based on their different responses, they were presented with an array of different strategies they could choose from to then build their implementation plan for their respective facilities based on their different needs. So overall, as you can see, the majority of participants found the tool to be useful and user-friendly and feel like they had the knowledge by the end of the tool to successfully implement their plan after completing the assessment. Participants also agreed that implementing the plan was feasible and that the plan was tailored to the facility's diverse needs. And as you can see to the right of the poster, there are a couple of top 3 tasks that they found to be the most useful for implementation. So overall, the Tech into Care Plus online tool is promising in terms of usability, feasibility, and acceptability to facilitate self-guided implementation. Although the study did have a couple of limitations, including a smaller sample size and not assessing veteran reach, results are promising and do support future steps to further refine the tool, expand to even more VA sites, and potentially continuing to assess patient outcomes and its impact. So that concludes my presentation, and thank you so much for your time.
Great, thank you. Any questions? I will start us off then. Can you talk a little bit about how they picked these different implementation tasks?
Yeah, sure. So based on the different types of facilities they have and based on the staffing needs, they're presented with different options as they go through the tools. So these are all tailored to their specific facility, or whether they want to do in-person trainings or online trainings, all of that, that's kind of where these tasks came from.
And I just want to quickly add that the implementation strategies that we presented in the decision tool actually came from prior work that we did even before I joined the team. So we gathered all the different projects leading up to Tech into Care Plus, and so we basically gathered all the implementation strategies that we found that other VA staff have used that were helpful, and then we basically compiled it into this large database and then programmed it. So based on the user or the staff purpose needs, they were presented with strategies like, Catherine mentioned, training other staff, disseminating information about apps within their facility through like facility newsletters, or including information about the apps in patient intake packets. So various methods.
Great, thank you. Very interesting. Any final questions? All right, thank you, Catherine.
Thank you, everyone.
Next, we have Dr. Shannon McIntyre. Can AI facilitate empathy among psychotherapist trainees?
Thanks very much. I'm going to go ahead and share my screen. All right, so this was a systematic review geared towards asking the very question of, can AI facilitate empathy among psychotherapist trainees? I'll also introduce myself. I'm core faculty at Antioch University in New England, actually Keene, New Hampshire. So I had the pleasure of doing this systematic review while kind of focused on how empathy can be kind of enhanced among psychotherapist trainees. I myself am a clinical supervisor, so I'm always interested in looking at how to enhance the clinical skills of psychotherapist trainees. And thinking that AI does have a potential role in this particular training program, we reviewed the literature basically from January of 2022 to March of 2024, and just kind of used the search terms artificial intelligence and empathy training in the search engine. And what we came up with was 108 total articles, which we then filtered based on their relevance to our research question. The result was actually only about 7 articles, but they covered 3 main themes, and I'll kind of go over those briefly right now for you. The first theme that emerged is that it basically suggested that AI very much can emulate empathy, and there's research that's emerging in the current, like, over the last 2 years that suggests that there's certain attributes that could be kind of helpful in connecting to people that in ways that would elicit empathy or help them hone that skill. So there's certain research that definitely does suggest that AI can emulate empathy, such as being more authentic, compassionate, etc. There's even evidence that AI coaching could perform as equally well to human coaching, which is pretty surprising. The second theme that emerged is that AI methodologies are currently being developed to evaluate psychotherapist efficacy. So this is with regards to attributes that are close to therapeutic empathy, but not quite. So, you know, there's tools that are being developed to, like, assess their sort of perception of empathy or affect, as well as their multicultural skills, suggesting that similar tools could be developed to actually assess their empathy as well. And lastly, which was the most promising theme, is that a study by Webb et al. In 2023 has actually come up with a chatbot or a tool that could train emergency physicians to break bad news. And this tool involves them having designed a prompt that they can input into ChatGPT and sort of elicit an actual conversation with emergency physicians to have them actually hone the skill of breaking bad news. So in conclusion, my colleague and I have actually suggested that the same kind of prompt could be changed and sort of tailored so that therapist trainees can also kind of use this to their advantage to develop empathy as well. So I think that concludes my presentation. If there's any questions, I'm happy to address them.
Great, thank you. Questions? Several questions in the chat. First one is, curious if there are common themes on how AI was used in empathy training in general.
So Interestingly, they haven't actually used AI in empathy training quite yet, but it appears from the research that's been published that they're starting to look at, again, like ways that it's been measured, ways that it's starting to be honed so that it can approximate empathy. And then there's research that actually suggests that there's ways to manipulate ChatGPT so that it can be used for empathy training. That's a great question, though. Do you want me to respond to the rest of these?
Yes, yes. Next one. Why did you limit your search to articles published between 2022 and 2024?
Yeah, that's a great question. From the outset, sort of looking at the articles, it seemed like the most articles published before 2022 were interestingly tended to be on virtual reality and the use of virtual reality to hone empathy and how that intersected with it. And it's only really in recent years that they've started to look at AI and artificial intelligence and its potential role. So we sort of limited it for that reason, but absolutely in future research, I think it'd be interesting to cover a broader span. So thank you for that.
Wonderful. Thank you so much, Shannon.
Thank you.
Next up, we have Iman Qasim. Please tell me how to say your name.
Oh, you got it right. It's Iman. I'll just quickly share my screen. Can you see the presentation? Yeah, okay. Well, hi everyone. Thanks so much for having me today. My name is Iman and I work at the Center for Addiction and Mental Health located in Toronto, Canada. And today I'll be sharing findings from the implementation of a mobile app to support individuals with schizophrenia spectrum disorders. So just for some background, recently, as many of us know, digital health tools have emerged to support individuals with schizophrenia spectrum disorders in managing their health condition. And while it's well known that digital tools like apps can support patient care and improve health outcomes, there is limited research on how best to integrate these tools into routine clinical settings. And so due to this, our team conducted a multi-site implementation of an app called A4I, which is designed to support individuals with schizophrenia spectrum disorders. And today I'll briefly just describe some of the contextual factors within the domains of people, culture, process, and technology, which impacted the implementation of the A4I app in each implementation context. So we implemented the A4I app in 3 different clinical contexts, where the first setting was within a randomized controlled trial, which recruited patients to use the app independently on their own. The second setting was a pilot program at an outpatient clinic in Toronto, which recruited patients to use the app in partnership with the clinician. And finally, the third setting was a PSW-led pilot program in California within a community-based outpatient clinic, which recruited patients to use the app in partnership with their PSW and their clinical team. Okay, so moving on to what we found, with regards to user engagement, Context 2 and Context 3 had the highest rates of engagement and interactions over a 30 and 90-day period, indicating that using the app in partnership with a clinician or a PSW improved engagement with the app itself. And with regards to the socio-technical factors that impacted engagement and the implementation, I'll briefly just describe some of the main findings. So under the domain of people and culture, the team structure and roles differed within each implementation context. So in Context 1, this was set in a pretty rigid research environment where research staff were leading the RCT. In Context 2 and 3, these were set in quite adaptable and fluid pilot projects with an engaged team of either project staff or PSW who were leading the programs. In terms of culture, innovation was baked into each of the organization's strategic plans. So the adoption of innovative tools like digital health apps were largely welcomed by clinical managers and clinical staff. Moving on to process, each implementation site followed a similar process to the implementation of the app. So this was in regards to patient enrollment, education and training, and ad hoc support that was provided throughout their use of the app throughout the pilot or the study. Additionally, in Context 2 and 3, the clinicians who were using the app in partnership with their patients received similar onboarding, training, and support as well. Educational and onboarding materials were also developed and tailored and customized to each implementation context. And this was tailored to either the setting or the patient population that was being supported. Finally, with regards to technology, patients in Context 2 and Context 3 were provided with a data plan and a smartphone device if needed. And so this really drove willingness to join the pilot. And in each context, the research staff or the project staff or a PSW informally took on the role of digital navigators, where they provided digital literacy training to some of the patients and provided tech support to both patients and clinicians when needed. So to conclude, we found that developing customized educational materials, implementing digital navigators to support use and adoption of the app, and providing ongoing technical support were huge facilitators of ensuring the successful implementation of this specific app in our different clinical contexts. So thank you.
Great, thank you. Questions? I have one. Could you talk about how the materials were tailored and customized?
Yeah, sure. So for each context, the implementation was obviously set in a different clinic. And so we worked with the clinical staff to develop either we had like swag bags that we would give to clients when we were onboarding them. And we developed different types of posters, different brochures and videos to train clients on how to use the app itself. And so each team kind of built similar training materials and onboarding materials, but they were tailored to the clinical site. And so if a rec therapist was the clinician who was supporting a client in one site versus a psychologist in another site, we tailored the training materials to sort of highlight the different aspects of an app that can be best supported for the patient when working with a specific clinician. And so it was really just working with each specific site and developing tailored materials with the site's logos, the clinic team names, and that sort of stuff to make it a bit more personalized and relevant to the clients who are receiving care at these different clinics and within these different settings too.
Great, thank you so much.
Thank you.
Our next poster, we have preferences for mHealth interventions to address mental health challenges among men who have sex with men in Nepal. Do we have the presenter here? Nope. Okay, we will go on to the next one. Do we have Dr. Paige Segan? Great, thank you. Oh, you're muted.
Thank you. All right. My name is Dr. Paige Segan. I'm an assistant professor at Johns Hopkins School of Medicine. I have no conflicts of interest to disclose. So as highlighted kind of throughout this conference, digital mental health applications hold a lot of promise to improve patient access to evidence-based care or treatments, as well as improve patient outcomes and reduce kind of just the general overall burden on the mental health system currently. But what we don't know is how consistently are these DMHAs integrated into routine clinical care. And so we basically examined patient and provider barriers and facilitators to the adoption and utilization of DMHAs, specifically within a healthcare system. So we had a targeted convenience sample of patients, 57, and providers, 100, who were recruited from a large academic healthcare system in the summer of 2022. And our findings highlight just in general here that DMHA credibility, usability, and accessibility are important facilitators and provider adoption and patient use. So specifically, we found that patients would be more likely to use a DMHA if their provider is a credible source of information and is able to describe clearly the reasons for why they think this would be helpful in their care. And also if the DMHA itself uses accurate information backed in science. Patients also reported that they would be more likely to use an app if recommended by their doctor or behavioral health provider or psychiatrist compared to an app recommended by a friend or family member. So they really wanted their provider to be involved in the recommendation process to, again, increase that credibility of the app and its ability to help the patient. Majority of patients reported that they'd also like apps that are free, fun, entertaining. So the usability and accessibility piece that they could use without Wi-Fi, with Wi-Fi, and that it can be personalized to them. So again, aesthetics are important. They want apps that look nice, are easy to use, easy to download, easy to navigate. And they also, I can go into specifics later on, but those are kind of the points for patients. For providers, they really want to also know whether the app is based in evidence and what the efficacy looks like for the app, and what kinds of treatment strategies are included in the app. Wanted to know randomized control trial evidence based off of the DMHA and treating specific problems. And they also wanted to get feedback from patients. So they wanted guided activities, ability for patients to practice skills and track that skill use. And then also that, again, that ability to communicate around kind of more of the practice. Our skill practice. Now, in terms of barriers, the big barriers on the patient side is highlighted here: privacy concerns. So how is their data going to be used? And then for providers, main barriers were patient costs, provider reimbursement, limited knowledge around apps, perceived limits to credibility, uncertainty about whether an app could improve patient outcomes, and then whether or not that app could really be personalized for their patient's needs. One thing that came out of this was also the discrepancies around patient and provider reports around timing of DMHA integration with regards to like stepped care models still requires further exploration. So like, could this be used while a patient's on a wait list versus already had an intake completed versus in established routine care? When do people feel comfortable recommending them as well as using them? So that's still kind of that's still a question mark. In general, kind of integration to be meaningful, we need to be examining key stakeholders, so our providers and our patients at different levels of care. So again, waitlist versus established care, to further address barriers, optimize facilitators, and then also hopefully build out roadmaps for best practice use in healthcare systems. And that concludes my presentation. Any questions?
I have a question. Yeah, thank you. It was a great presentation. I just wanted to know what was the age group of the patients recruited? And
So
also, sorry, one more question was regarding the providers. So, sorry, the mental health applications, were they focused on a specific disease or just primary care mental health focusing on?
So it was in established mental health clinics. And so going to your first question for the age of the patient, the mean age was 31 with a standard deviation of 5.76. And the degree or license type of the provider, so they were mostly within mental health clinics, some primary care, but the majority were PhD, PsyD, or LCSWC.
Perfect, thank you.
Mm-hmm.
I have a question as well. So from the private sector, I have built an application for digital mental interoperability that is using standards and interoperability. So is there, as a sole proprietor, so is there any collaboration between public and private sector that I can leverage, or for app evaluation in terms of, and how do we better align our efforts so that we are? Yeah.
So I think you're highlighting one of the important pieces is that collaboration is so crucial. And so if I'm understanding your question is, and feel free to interrupt me if I'm not, but one of the things that we were thinking of is, could there be kind of partnership between industry and either healthcare settings or, private practice or whoever, the providers themselves, in understanding what their patient population is looking for. So almost kind of have like a focus group and then a panel of kind of digital health experts that are advocating on, what the patient population is saying they want and need. So kind of thinking of what is that actually going to look like? Is it going to be panels? Is it going to be Advocates, is it going to be, just partnering with different institutions? I think it's still a bit of a question mark. I don't know if I really answered your question well, but I feel like that's part of where the research needs to go to make sure that the apps we're developing are actually going to be used by the patients we're developing them for.
Exactly. Yeah, that's sort of my question. Like, I mean, a lot of work is done as a private sector, but if the apps are not evaluated, not vetted, then what's the use of that? And public sector has more resources at their disposal sometimes for research and development. So if building an app is one thing, getting it out to customers another thing. And so, yeah, that's sort of.
Yeah, I mean, we have, I looked recently, like 20,000 or at least 10,000 like mental health apps out there. But providers, so something that I didn't talk to specifically, but a lot of providers were actually recommending apps and were very welcome and open to using them as part of their routine care. But when it came to their understanding of apps, it was quite limited. So the inconsistency in which people are already kind of or recommending them, but not knowing their efficacy is a little bit concerning. But then also the other side of it is, how do we partner with these providers to educate them on apps to, again, then make them feel credible to then get inpatient buy-in. So again, yeah, it highlights the bigger issue that there's tons of apps, but how are we going to take the apps that exist and integrate them into actual care, and specifically healthcare settings? I think that's still kind of, we're trying to figure that out. But partnering with institutions would be, again, highlighting the importance of the key stakeholders, I think is what I would recommend.
No, thank you.
Mm-hmm.
Great, thank you. There's one question in the chat, if I could ask you to answer in the chat for the sake of time, so we can move on to our next poster. Next poster, overcoming the potential drawbacks of artificial intelligence in psychotherapy, literature updates.
Hi, everyone. I'm going to share my screen. Give me a minute. Okay, hi. My name is Ozege Agaze, and I'm a graduate from the College of Medicine, University of Lagos. I'm here to talk about the literature updates in psychotherapy. And the methods that we use was search of PubMed, Google Scholar, of peer-reviewed articles. And of the 95 identified articles on AI, we actually selected 10 articles that discuss the applications of AI in psychotherapy. And the focus was on the benefits, drawbacks, and potential solutions of the drawback. And I also forgot to say that we have no conflicts of interest to declare for this study. So the benefits of AI can never be overemphasized. I mean, we spent a better much of today discussing all the benefits. A great one being that there's now, at least we have more access of mental health services for the underserved populations. Then the drawbacks that we saw in our study includes that there's ethical issues, a very big one, and is affecting issues like the autonomy, beneficence, non-efficiency, and justice. And also there's also concerns regarding technical malfunctions within psychotherapy using AI, and also the data security and breaches, which I've heard from so many people during this presentation, and worries about privacy are a significant concern. And AI has the potential to introduce bias, and sometimes reflecting biases present in the data used during training. So from some of the drawbacks that we saw, possible solutions include that patients, we are required to offer patients a comprehensive understanding of how AI works. Like in some of the study that we saw, like some for adolescents and teens, some of them actually think that there's someone behind those apps and answering them in real time. And for some of the apps, it may not be so. Also, AI should undergo similar rigorous risk assessment and regulatory oversight as other medical devices before being approved for clinical use. Right now, that is not so, and that's a big concern. And the risk of bias can be reduced by using pre-processing techniques, model in processing strategies, and post-processing adjustments. So I knew I kind of breezed through my presentation because I know that we have just 2 minutes, and I tried to stay within that 2 minutes. So if you have any questions, I'm open for any questions right now.
Great, thank you. I have a question. I'm curious, who should be involved in developing these solutions? Who are the stakeholders here?
Okay, yes, and that's a very curious one because I'm also big into research, and we know like some like FDA is all over research from you even thinking about it, IRB, everything. So who should be? I'm not sure, but because that even right now, currently, no professional boards actually regulates all these apples. So for me, I think it's something that we need to research more, and we need to start putting things in place. Of course, professional board involved will be the psychiatrists, the therapists. I mean, a lot more people should be involved, but this is something we should start thinking about because every day we have new apps coming up, and with no regulation in sight, we have the potential to see more drawbacks in AI use in psychotherapy, despite the significant gains that we've made using AI in psychotherapy. So right now, I don't know, it's open to everybody to say that to look for a solution to that because there's none currently right now.
Thank you. Any other questions? All right, let's move on. Oh, did someone have something? No.
Thank
Okay.
you.
Thank you. Next poster by by Edward Silber, assessing interpersonal risk factors for suicidal ideation in community-based clinics with large language models.
Hello, I'm gonna share very quickly. Let me just move this right. So, thank you all for attending. Very briefly, our conflict of interest statement is that 3 of the 4 authors, including myself, are employees of Elios Health, which is the AI platform that's going to be described here in this presentation. To begin, recent research suggests that suicide is the 11th leading cause of death in 2021. Interpersonal theory of suicide states that suicidality occurs when individuals experience perceived burdensomeness and thwarted belongingness. The objective here was to see if large language models could augment our understanding of this phenomenon by analyzing textual databases of clients endorsing and denying suicidal ideation. Here we analyzed about 12,000 progress notes of 625 clients. Themes related to high risk and interpersonal discussions were extracted from the notes. And from there, we use separate one-way ANOVAs to compare frequency of themes discussed between the 2 groups. Overall, the results suggest that compared to those denying suicidality, clients endorsing suicidal ideation discuss guns more frequently, discuss interpersonal skills less frequently, and discuss friendships less frequently. Overall, the conclusion here is that there was additional support for interpersonal theory of suicide. these results suggest that building friendships and interpersonal skills may serve as a protective factor for suicide. And now we have a better understanding that large language models can offer nuanced intervention and insights, especially for programs where suicidal ideation is prevalent. Next steps moving forward, we believe that we can examine the impact of training therapists to recognize and respond to certain discussion themes, especially related to high risk and interpersonal themes, and potentially develop some sort of predictive model to using these extracted themes to identify high risk clients who might not be explicitly endorsing suicidal ideation. And that's everything. Thank you.
Great, thank you. Do we have any questions? Could you talk a bit about how those notes were analyzed?
Yeah, so it uses what we call this a BART, bidirectional autoregressive transformer. It's a BART AI tech where you're basically using bidirectional encoding, which is considering context from left to right of the token or the sequence that's being presented in front of you. And then you're also simultaneously using these natural language processing to break down the tokens into words or characters, just very detailed breakdown. And then it also uses an autoregressive decoding model, which generates one token at a time. And it's similar to GPT, where you're trying to essentially, it generates tokens based on the previous text. So it's almost like it's trying to guess what the next word or the next token would be. And so that's how that was analyzed.
Thank you. We have a question in the chat. I'm curious about the difference in session attendance between those with SI and those without. Do you believe this is due to referral out of care due to risk?
Let me just read the last part of that question. Do you believe this is due to referral out of care? Yeah, well, so yeah, one result that I didn't mention was that there was a higher attendance rate amongst those that denied suicidal ideation. We don't know exactly why, or we didn't really assess why. I can to answer that question, due to believe this is due to referral out of care due to risk. I don't know if I necessarily like understand the question. Are you saying, are we referring, or did they refer clients out due to risk? Because I don't know if that was the case.
Yeah, I think my question was if those folks like increased in risk during the trial or during care, if they ended up their care earlier because they were in need of a higher level of care and were referred out, or if you believe that there was some other mechanism there.
Right. It's a plausible conclusion. It very well might be. I'm not sure. We inherited this data from the community-based clinic that we were working with, and I don't think there was a detailed analysis on what the attendance looked like. But
yeah,
I mean, certainly something to think about. I'm not entirely sure.
Thank you.
Another question in the chat. Was there a typical gender distribution of the clients whose notes were analyzed?
Yeah, and then similarly, we didn't have a demographic breakdown of who the clients were. I think mostly for confidentiality purposes, we really just received the data. We'd received the notes that were being presented. We didn't receive any sort of demographic data, so I'm not entirely sure either.
Great, thank you. And do we have anyone here to present on preferences for mHealth intervention to address mental health challenges among men who have sex with men in Nepal? We have a presenter. All right, if not, we will end early. Thank you, everyone. Thank you to all our presenters. Great job.